Is is there anyone who requires English translation? Is there anyone? Is there anyone requiring English translation? Okay. Hi. So we'll translate for you. That's not a problem. I expected there would be more people in here, but maybe they haven't yet come. But since we have a sort of time schedule that we have to keep to, and there will be a third workshop afterwards, this is why I have to start. As I said, Hans Jungblut will come too. He is from the UK, and I'm working with him quite often, collaborating with him. I try to do it in German. I speak German with family and friends very often, but not so much with patients, and in particular not with colleagues. And for that reason, I will have to kind of search for words sometimes, but I think it will work. Okay. I'd expected I don't really know why it doesn't work. Now it does. Well, that's a team I'm working with, and this is in Nijmegen, at the east of Holland. This is just 120 kilometers here, this distance, and there are 6 centers for muscle diseases in Holland, or university teaching hospitals, and we're in Nijmegen, in the Radboud hospital, where I work together with my colleagues, which are neurologists, pediatricians, neurologists, rehabilitation specialists, and nurses. And this is a muscle team, Nijmegen. And we also very often cooperate with the Society of Muscle Diseases in the Netherlands, Spearsis, and that's muscle diseases. And that's a patient organization, and the Princess Beatrix Foundation is the fundraising foundation. Now let me see, this is Nijmegen. This is at the river, the Rau, we call it the Rhine. And the hospital is located there. It's a university teaching hospital. It's close to the university premises, and Germany is just 8 kilometers away. So there are some German patients as well, but not very many. And already for about 8 years, I've had a very good cooperation with Mr. Hans Jungblut in London or Suzanne Prefes in Basel. She has a lab for the research of alterations in the RYR1 gene. And in Nijmegen, I work together with genetic specialists and neurologists, and with Mark Schluck, who is a doctor in Nijmegen. He's very much specialized on malign hyperthermia in the Netherlands. The reason why I was asked to come here is that with this group and with Heinz, we have examined a group of patients with an alteration of the RYR1 gene, RYR1, but I will say RYR1 because it's easier. It's a group of patients of different ages from birth to over 60 years of age. And we described, or we collected the symptoms and the diseases. Centronuclear myopathies are just one part of it. It's a whole scope of various diseases that we take care of. And it was a group of patients of which we received medical data. They were all tested in our hospital from 2008 to 2012. Then I examined the patients myself, or there were patients that came from other hospitals and asked the hospital for more data. And in total, we had 272 patients, and in 77 of them, we found an alteration of the RYR1 gene. And the diagram here shows that most of them had an autosomal dominant disease, a small part of them recessive, and there was a part where we didn't know. As we heard this morning, this is to do with the fact that very often there are some alterations and we don't really know how they come about. And then it's very important to do further diagnostics, but we don't have the possibility yet, so we have to try to do that in the future. Usually the alterations were differing. It's not the same alteration in every patient. Very often there are new kind of mutations that we weren't aware of. We don't know whether they really caused the disease. And now we see what different kind of diseases were. We had here centronuclear myopathies are here. That's one patient in this group. The largest part, about 1/3, was malign hyperthermia. And central core disease, CCD, was also a large group. And I don't really know how to say that in German. Exercise-induced rhabdomyolysis, which means that patients after physical stress, after sports, for instance, had rhabdomyolysis, so that there were quite a lot of symptoms in the muscle, and you felt weak for a while, and the CK levels in the blood were elevated, and that can also be very dangerous for the kidneys. And we also had cases of multiminicore disease with a axial myopathy. Usually it's the back and abdominal muscles, and congenital myopathy, not otherwise specified, NOS in other words. And there were also people with only an elevated CK in the blood and fatal akinesia. That's a very severe weakness directly after birth, and the child will die at once. And there was one patient with another myopathy and one with Kinden-Barrow syndrome. I think Heinz mentioned it this morning. But it started sometimes. It presented itself in different ages. They're not only in children, but sometimes the patients were 60 years old when they first had developed the first symptoms. When I talked to Heinz, I said, "Well, congenital myopathy at the age of an adult, isn't that strange?" He said, "Okay, it's congenital, but on the other hand, they go and see a doctor for the first time when they are 30 or 40 years old. But when you ask them properly, they say, well, when I was young, I didn't do much sports. Or I wasn't good at sports. When I was in a team, I wasn't able to run fast, and my father couldn't as well. It's part of our family. And I started then to go fishing, for instance, because that worked well. So actually, you try to find things that are easier for you to do in such cases. And it's my experience usually that when in adults you find the diagnosis of congenital myopathy, that usually you find out that the symptoms have been lasting for a long time, but they weren't severe enough to go and see a doctor. And there was just one patient with centronuclear myopathy. I haven't seen him myself, but he was in another hospital in Holland. I'm just showing it briefly here. That's an example here. I think he's now 30 years old. And since he was in the middle of his 20s, it got more and more difficult for him to walk. And he had a RYR1-induced centronuclear myopathy. And most important is at the bottom. At the age of 29, he was still able to live independently. He got care from a nurse, and he still worked as a web designer. So that's totally different from the myotubular myopathies, but there's not so many cases. We have gathered data of one case. Heinz had done that. Heinz had collected data on them, and he knows more patients of that certain conditions than I do. In general, we can say that if you look at the whole scope of diseases related to RYR1, this is a huge scope. On the one hand, you might have patients with severe weakness already at an early age, and on the other hand, you find adults who only run into problems when they do sports, and it's all to do with RYR1. And it's not enough that some mutations of RYR1 cause not enough calcium secretion. Others maybe have different effects and can cause different diseases. For pathologists who look at such things under the microscope, I mean, we've seen these kind of figures before. That's the central core disease. In the middle of the muscle cells, you see this kind of white regions. And every muscle pathologist will be able to recognize it easily. On the right side, you see a microscopic image of a blue staining somewhat. And if you don't know it, you won't see it. And you think, oh, it's a matter of the staining. But this can also be a symptom of a muscle disease, which is caused by RYR1 alterations, and it can also change over the age. This is 3 biopsies of 3 different patients at the age of 53, 63, and 64. And you see here it's a little rough up there, but you see the cause here down there. So if you couldn't find something in him when he was younger, it might well be then when you repeat the same thing later on, 10 or 15 years later, then the biopsy could look totally different under the microscope. And I think it's fully okay to show it like this, because in Nijmegen, if we do needle biopsy, we don't have a very big biopsy, but we have a needle biopsy with a cross-section of 5 millimeters, and you can do that every other year, or every few years at least. And all patients that I saw said, okay, it hurts when you do it, but after that, it's quickly over. It will heal quickly, and you don't see any scar afterwards.
Now, we now have 106 non-related patients, and the new cases that have come together in this group have all diseases from the spectrum that I have shown earlier. We have started a biobank for congenital myopathies. So everybody who comes to the hospital when a blood sample has to be taken and tested, we can take some tubes, some muscular tubes, and store them in the biobank. So the elements that have been taken from earlier, the samples that are still present and they can still be used for research. Anytime we do a biopsy, we believe that in the future there will be such developments that we can use these samples again. Also working together with our child neurologists, we have discussed that we would like to do more to help organizing the biobank for CNM patients. A few examples that I would like to share with you from adults, people who are over 20 years of age. These are 4 examples. One example is a girl of 14 who's not fully adult, but also a CNM patient. The second example is a CCD patient. This is one of the main groups of CNM that we have. This is a man who came to the neurologist when he was 39 years old. He said, I was never good at sports. I had surgery at a hernia and also at the chest. The pectus was infected. My mother and brother are not good in running either. They don't run fast or far. And the son of my brother has central core disease, been diagnosed. I did not see the brother, but this patient said, now I have difficulties running, I can't climb stairs, I'm worried that I won't be able to do physical work anymore. I used to work in a factory, and it started to get more and more difficult to do the work in the factory. He did have muscle weakness, but not a grave case. He wasn't able to walk on his toes very well, and he couldn't run. The biopsy showed that there was a mild myopathic development, and there are also changes in the staining that I have shown earlier. This man, for example, didn't want an example from an anesthetist, but his brother did want one. It is very important to differentiate between those two, because the brother could develop malign hyperthermia. Another case is axial myopathy. That means that the muscles from the stomach and from the back are attacked. And we have seen many patients where this has come up. This man, for example, was 48 years. He said, me too, I was never good at sports. And since the age of 40, I'm getting worse and worse at walking, getting upstairs, etc., etc. He said, when I walk, my stomach goes to the front and my shoulders drop to the back. When he came to me to be diagnosed, he had a strong case of atrophy in the back. You can see that the muscles at the back are thinner than they should be. This is called axial myopathy. We have seen that he had that not only at his back but also in other areas, and it can be compared to this patient where it's not as bad but also clearly visible. This man is 39 years old on the picture. Nothing is clearly visible, but he says that he did have pain because he had to milk 60 cows a day. This was also an RYR1 case. Another example is in this man, where we have seen this first, but also in other examples later, that we were only able to diagnose the CNM after several visits with different doctors. Another example is the sister of this young man that Heinz showed this morning. His sister came when she was 14 for the first time. She had a severe myelitis. She had been on a sports camp with her school and then felt severe pains. Her CK value was 400,000 when it should have been 200. That meant that she came into intensive care, received dialysis, and we looked and looked what would be the cause for her disease. We found that it was also a change in the RYR1 gene. Her life plans changed drastically after that. She had 5 further episodes of rhabdomyolysis that can be triggered when she does a lot of sport, or when she has a viral infection, or when she's stressed because of exams. So there are different triggers. Her brother, on the other hand, is 2 years older, has the same disease, has only slightly increased CK value, does a lot of sports, as you can see below, 5 days a week. His mother says, don't do that, but he still goes to the gym 5 days a week. He was never diagnosed with the same sickness or the same feeling that his sister. We cannot explain why she has it and he doesn't. There will be other genetic factor involved that we don't know yet. A similar story is from another young man who came to a hospital when he was 17. He was a cyclist. He used to ride his bike a lot. He wanted to become a professional cyclist. When he was 14, he had a first episode of rhabdomyolysis. He always trained very hard, but still, after recovering, there were always new onsets of rhabdomyolysis. He just used some caffeine gel, something that many cyclists use after stressful rides. And there were 2 changes in his RYR1 value as well. The test that was sent in the hospital was positive. His uncle had come to the hospital a lot earlier, and when he had gone to the hospital, we weren't able to diagnose this. But now, when he came again, we were able to find the link. And the therapy is doing him a lot of good. He's feeling much better now. The final family that I would like to talk about has a case of malignant hyperthermia. The girl, the young lady, when she was 14, experienced an episode of malign hyperthermia. Back then, her mother said, well, we have to run further tests if that is really the correct diagnosis. She did genetic tests later, and when the family did the tests, indeed, her mother also showed to have 2 mutations in her RYR1. The daughter had 1. The mother also had central core disease, a myopathy, but the daughter had normal strength and just 1 experience with malign hyperthermia. That means that there are families with completely different developments in the disease or in the mutations of the gene. Sometimes when parents have 2 mutations, the children can inherit only 1. And that means that some children are more sensitive than others. About the future, what we have to look at is the relationship between the genotype-phenotype coupling to see what are people suffering from and what is actually responsible for the suffering. Is it doing sports or infections or the use of medicine? This is all information that we need to gather in order to give the best possible therapeutic advice. This boy I showed, he wants to continue to cycle. He was very certain he wanted to continue it, but after further therapy, he realized that it was impossible for him. I will also try to start a further study to determine how muscular disease is developing throughout the years with adults. Finally, we want to do a trial in order to find out if it is useful to train strength and fatigue. Thank you very much for your attention, and I'm looking forward to your questions.